morning, everyone. This is Leanne Larange, and I'm speaking to you from Physiotherapy Alberta's office in Edmonton. Before we begin this morning's presentation, I just want to start with a little bit of an orientation to the screen in front of you. So on your screen, you will be seeing, hopefully, the slide deck in the center of this screen. To the left, you will see the speaker bio pod, where you can read more about our speakers this morning. To the right, you will see the question and answer pod, where you can type in a question for our speakers at any time during the presentation. The speakers have indicated that they will take questions at the end of the presentation, but you may certainly enter them at any time, and that's also where you can enter any questions if you're having technology issues, and we'll do our best to help you troubleshoot those. And lastly, at the bottom dock, you will see a little widget that looks like a sheet of paper with some writing on it. If you click on that widget, you will find a handout for today's presentation. So you can take that away with you and review it again at a later time. As a note, this morning's presentation includes a video clip. And when the video goes live, you should automatically see the video. It should launch and resize into the center of your screen. However, if you don't have that experience, if you click on the media player, which is just above the speaker bio, that is where you will find the video. So if it doesn't automatically launch for you, that's where you will find it. And with that housekeeping taken care of, I would like to begin with a land acknowledgement. So again, my name is Leanne Larange, and I'm speaking to you today from Edmonton. And I would like to begin today's presentation by acknowledging that Physiotherapy Alberta's offices are located on Treaty 6 territory, as well as the Métis Nation of Alberta's Region 4, which has been and continues to be the home of many Indigenous peoples since time immemorial. Physiotherapy Alberta recognizes that Indigenous peoples have been helping many to live healthy lives on this land since long before settlers arrived. And with that, we commit ourselves to helping move people forward in their journey towards a good life, and doing so in a way that follows the spirit and intent of treaty, that of peace, friendship, and understanding. We also recognize that people from across Alberta and beyond are joining us today, and we encourage you to take a few moments to learn more about the lands, peoples, and treaties with which you may be in relationship. And now it is my pleasure to announce this morning's speakers. Dr. Patty Thiel is a sociologist and physiotherapist who works as an assistant professor in the physical therapy department at the University of Manitoba. Dr. Sandra Weber is a physical therapist and researcher in the Department of Physical Therapy at the University of Manitoba. And Liz Harvey is a physiotherapist and senior instructor at the University of Manitoba. Ms. Harvey is also a PhD student at the University of Manitoba. And with no further ado, I will turn the platform over to our speakers.
Good morning and welcome. Thank you, Leanne, for this invitation. I am Patty, and I just want to say that I'm here today. I'm really thrilled to be here today. In part, I have been studying weight stigma and physio in healthcare, for actually almost 20 years. I did my master's and PhD on the topic, but in healthcare generally. So I'm thrilled that we are opening up this conversation in physiotherapy specifically.
Sandra, do you want to introduce? Perhaps she's having trouble. I'll go ahead. My name's Liz.
Sorry.
Oh, you're there? Okay. Sandra?
Sorry, I'm here. Yep, I'm here. Thanks very much for the invitation, and I hope everybody enjoys our presentation today. I don't do a whole lot of work in weight stigma, but I am interested in topics that are relevant to education in physiotherapy, and I think that this is our topic has relevance for our students today as well.
Yeah, and I'm Liz, and I got into this project as part of my PhD work as in my bridging program. So I helped run this with Patty and Sandra as my supervisors, and I'm also interested in how we can start making change in our curriculum as well. And we offer this session as an opportunity to explore the topic of weight stigma within physiotherapy. We are only starting to learn about these issues in our profession, how weight stigma manifests in physio practice, and what supports you need as physiotherapists to ensure your practice is inclusive of all bodies. I just want to give a little note about the language we're going to be using in this workshop. We use the word fat as a neutral descriptor of bodies, consistent with fat acceptance movements and the field of fat studies. And Leanne did a great land acknowledgement, but we just want to acknowledge that we join you today from Treaty 1 territory in Winnipeg, where we live, play, and work. These are the original lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene people, and the homeland of the Métis Nation. The image on the top left is the flag that represents the 7 First Nation communities that signed Treaty Number 1 with the Crown in 1871. The one in the middle is a picture of an urban Métis community called Roostertown that was erased from the Winnipeg landscape in the 1960s to make way for a shopping mall and a high school. Many of you, as Leanne said, are tuning in from different Indigenous lands. If you'd like, you can type in the Q&A your own land acknowledgement. We recognize the harms and mistakes of the past and the present, including those impacting the health of First Nations, Métis, and Inuit people, and including those done within healthcare. The picture on the bottom right is a mural of Brian Sinclair, a vulnerable Indigenous man with disabilities who entered a Winnipeg hospital emergency room in 2008 for a bladder infection caused by a blocked catheter. He was found dead in the emergency room 36 hours later, still waiting to be seen. The work we are discussing today deals with one particular form of stigmatization, but we acknowledge that different forms of stigmatization and discrimination often coexist and compound. We affirm our dedication to work in partnership with Indigenous and other stigmatized communities towards reconciliation, including health system improvement. So we'd now like you to do a little reflection, take a few breaths, and consider how you're feeling, what's happening in your body. If you'd like, you can use the feelings wheel that's here on the side to help you name your emotions, and you can just jot them down. Hopefully you've written a little note to yourself. And we want you to think about as well, what are you thinking or wondering about? And was there anything that surprised you? And now I will turn it over to Patty.
Thanks, Liz. So stigmatization, at its sort of basic definition, involves actions that build upon and reinforce labels and stereotypes applied to different groups. Now, stereotypes are when a society assigns personality characteristics to a group. And of note, stereotypes can be positive or negative. Stigmatization specifically is about the ways in which negative stereotypes assigned to groups lead to individual people being treated as inferior or as an example of the stereotype simply because they are members of that group. So stigma as a concept draws attention to action. It's about how negative stereotypes against certain groups manifest in our communities. And this includes actions that people can take against themselves. For example, self-blame. People can isolate themselves based on how much they've internalized stigma. They will, avoid putting themselves in situations where they risk being further, excluded or stigmatized. And that speaks to the next level, which is that interactional level, that interpersonal, right? So bullying, microaggressions, forms of exclusion, things like people looking in your grocery cart and tisk-tisking as they're walking by you in grocery stores. These can be verbal and nonverbal and are often, if people in larger sizes have established this experience is highly frequent. The other form is structural forms of stigma. So this is things like access to resources. So people from stigmatized groups are generally less likely, for example, to be able to find employment or get promotions. Things like architecture, so the issue of misfitting in public spaces, so the design explicitly communicates that the space was not designed with you in mind, as well as media portrayals are part of how those messages are reinforced. And of note, these stigmatizing actions shape people's experiences every day as well as their health. Now, I come to this topic with a fundamental justice commitment to this work, but it's also important to recognize that stigma is a threat to health. Chief Public Health Officer, who we all know now, Teresa Tam, 2019 used her office's annual report to bring attention to stigma explicitly. And this report names healthcare as one of the sites of stigmatization. Stigma impacts health in multiple ways. It is a social determinant of health in that language. It is preventable, but this needs active work in multiple institutions to address. We're here today because of the ways that the injustice of weight stigma manifests in physiotherapy care. Weight stigma is premised on 3 common weight myths that circulate in our society. The first is that weight is under personal control. Rather than recognizing that weight is just like other cardiometabolic markers like blood pressure, blood sugar, cholesterol, and others, many people hold on to the belief that weight simply reflects lifestyle, the second myth. Specifically, the stereotype links thinness with motivation, with knowledge and commitment to certain physical activity and eating patterns, while fatness is stereotyped negatively as reflecting a lack of motivation or commitment. The third myth is that weight is highly malleable in safe ways. If we have learned anything from decades of studies trying to make fat bodies thin, it's that weight is not highly malleable in a way that is safe and sustained. It's very rare for lifestyle changes to produce a sustained reduction of anything beyond a very modest reduction of weight. So I'm happy to share references to address these myths. I just want to flag that with my email at the end of the presentation. To decide how to disrupt weight stigma, we need to appreciate how these myths are embedded in practice. So this can come up in assessment and treatment. So at times, clinicians are doing less assessment, assuming that weight is the problem or that weight itself speaks for behaviors, right? So they're treating a bodily characteristic as telling them what they need to know. The other is a sort of weight as the catch-all reason. So when things are uncertain, when we don't yet have a diagnosis, weight is often used sort of as the scapegoat, as opposed to saying we don't yet know what the cause of this problem is. Both of these of note delay diagnosis and access to appropriate treatment, which is important to think about in terms of all of our epidemiological studies that sort of make associations between weight and certain outcomes, or higher weight and certain outcomes. How much are we actually controlling for these quality of care problems? There are issues of insensitivity while measuring weight or body size or general handling, judging a patient for treatment failure. So the idea that the patient failed, quote unquote, as opposed to the treatment failed the person. And relatedly, labeling people non-adherent. This is particularly relevant when people are caught up in the weight myth that big changes in weight are possible through lifestyle tweaks. The other thing is a more subtle thing is fewer emotional rapport building statements, something I'll explain a bit more later. It shows up in setting goals. So either clinician or patient can initiate weight reduction as a goal, but weight reduction is an outcome. It is not a behavior, right? And so it'd be like goals to reduce blood pressure, right? It's an outcome, not a behavior. Giving poor quality or unsolicited weight reduction advice and pointing out that weight is a problem without offering practical advice or support. So for example, overly simplistic eat less, exercise more, sharing the anecdotes kind of things happens in clinic. The last way that it can manifest is in structural kind of aspects. So when we have a lack of appropriate seating, equipment, gowns, and the like, can in the clinical environment also show up in our education materials and our visual environment, our posters on the wall, etc., that perpetuate pro-thin and anti-fat biases and myths. So now I'll hand over to Sandra, who will introduce our quantitative study exploring attitudes in physiotherapy.
All right, thank you, Patty. So my name is Sandra, and I was the lead researcher on our quantitative study in this program of research. We conducted a survey of licensed physiotherapists and physical therapy students in Manitoba in the fall of 2019, and we had three main objectives. The first was to measure physiotherapists' orientation to health and fitness. The second was to measure their attitudes towards fat people. And the third, to see whether health and fitness orientation are associated with negative fat attitudes. Our survey included 3 questionnaires, and we obtained complete data from 221 participants, representing a response rate of approximately 28%. Our survey consisted of some basic demographic questions and 3 questionnaires that have previously been shown to be reliable and valid in samples with similar demographics. We included the health orientation scale by Snell et al., which measures things like health consciousness, motivation for healthiness, and health control. The second part of our survey included components from Cash's Body Self-Relations questionnaire that focus on fitness and health orientation, fitness and health evaluation, as well as overweight preoccupation. And the third tool we employed was the Fat Attitudes Assessment Toolkit. It covers 9 domains and was developed by Trish Kane in Australia. 4 of the 49 questions in the toolkit are listed on the right of this slide. Take a moment to think about how you would answer these questions if your options ranged from strongly disagree to strongly agree. Now I'm going to briefly present our findings. Our sample of physiotherapists scored high in all of the health and fitness categories assessed on our scale. In general, physiotherapists scored low on overweight preoccupation. Mean values for the majority of the fat attitude categories assessed suggest that physiotherapists expressed positive attitudes towards fatness and fat people. But, interestingly, 38% disagreed that weight stigma is serious, 72% provided neutral or negative responses to statements about fat people being attractive, and 82% attributed responsibility for fatness to the individual. This finding that physiotherapists scored high on attributing responsibility to the individual is interesting, and it has been demonstrated in other studies conducted in PTs. Yet, in our sample, respondents also agreed that genetic, biological, medical, and other influences outside one's control contribute to body weight, and that factors related to social disadvantage, economic situations, and social inequity also contribute to fatness. These results highlight the complex nature of fat attitudes and the need for further research to better understand this paradox. We also use structural equation modeling to investigate associations among these constructs that we studied, and we were able to generate a model that exhibited good fit. Interestingly, we found that age affected fat attitudes. Physiotherapists who were older tended to have more positive fat attitudes. We found a weak link between health orientation and fat attitudes, such that people with a greater orientation to health demonstrated less positive fat attitudes. And we found a strong association between fitness orientation and health orientation.
In summary, results of our study determined that physiotherapists are generally highly oriented towards health and fitness. And they also generally have quite positive attitudes towards fatness in fat people, although their scores on some select items were concerning. We found that fitness orientation was strongly linked to health orientation, but associations between health orientation and fat attitudes were weak. Therapists who were older had more positive fat attitudes. We intend to continue to explore factors that influence these relationships with our program of research. For example, we would like to examine the influence of gender, which we were unable to do with the current sample that was largely consisted of women. But we know that attitudes alone do not offer a complete picture of where we are at as a profession. Attitudes do not always match behavior. And now I'll pass this over to Patty to present some ideas about addressing weight stigma in physiotherapy practice.
So like all forms of discrimination, the work to disrupt it means addressing the actions that reproduce weight stigma. So when we offered a longer version of this workshop to physiotherapy clinicians and trainees in Manitoba, we learned it was the action part that therapists were quite unfamiliar with. So, things you can start with. Audit your clinic's physical environment. Seating in particular is fraught. This came up with our public engagement group, which is no surprise given it comes up repeatedly in the literature. A lot of spaces in our society are simply not built for larger bodies. They are physically painful and sometimes unsafe if you have a heavier body. So think about your entrance, your seating. You want a variety of seat widths, with and without arms, with space in between. Think about what's in your clinic rooms, as well as your clinical spaces, as well as your waiting spaces. Think about examination tables, sturdy step stools. And one thing that our public engagement group also mentioned is often in a physiotherapy clinic, you are changing your clothing. Have you got a space where there is room to move if you are not in a small, slender body? And one thing that they asked of us physiotherapists, or brief physiotherapists, is to post photos of our spaces on our clinic's website, showing these accessibility features and images. The idea is to make it easy for people to know that your clinic has what they need. Then, you're thinking about equipment. The goal here is to try to make this a really seamless experience. So you're thinking about, if you have clothing, what range of clothing sizes do you have? Do you have a full range? Do you have durable equipment that meets the needs of heavier bodied clients? You should know the weight limits of your clients, your equipment, so that you can be sure that you are providing them with safe care. You want to have the appropriate equipment nearby so use is easy, and you want to use the most appropriate equipment for each client without comment. The idea, again, here is seamless experience. It's just all happening, and there's no fuss. In terms of your visual environment in your clinic, you're going to think about the magazines you have in the clinic, the educational pamphlets, the posters, and you want to remove those that center or praise thinness and dieting, that promote the idea that all bodies can be thin, again, that promote that weight myth, that equate thinness with health and fitness with lack of health, right? So we are wanting to interrupt the reinforcement of pro-thinness and anti-fatness and ensure that we are promoting whole person ideas of health. So you want to fill your environment with health-affirming literature that supports people no matter their body size. So this is sort of health at every size thinking. If you are making any sort of visual pamphlets, posters, that sort of thing, you want to include images that are humanizing. That includes a range of body sizes, but of course there are other forms of bodily difference and diversity that you could consider including. At a minimum, you want to have people with faces. There's this thing really well recognized in the fat activist and fat studies fields that are around the headless fatty phenomenon, that images are sort of truncated bodies, no heads, a lot of black and white, or if there is a face, it's often not smiling or happy, right? So you want humanizing images, and you want to make sure these do not reproduce stereotypes. When you're thinking about assessment, the first and foremost advice is to respect the client's healthcare priorities and address their chief concern. I think when I think about the different professions that I've studied, I know that this perhaps is less commonly an issue in physiotherapy than it is in some other types of healthcare. But it is still, first and foremost, an important thing to have top of mind. You want to ensure that you perform the same assessments that you would for center body clients with similar symptoms, right? So you're making sure that you are not skipping steps because your sort of cognitively implicit biases are saying that this is weight. You want to handle body fat with care. Even just quick, unintentional handling can make people feel very vulnerable, right? So being really thoughtful about people's sensitivities because they're continually, routinely experiencing mistreatment by others. If you want help to move a body part, you just be kind and clear and be thoughtful about your tone of voice and your clarity in that respect. So check in about comfort. This is something you do with all people routinely. And you should be assessing health-related behaviors if it's relevant. So if there's going to be behavior-related goals, then you should have a sense of where people are so that you can at least give them some advice where you think that there's room for things to improve. And by those behaviors, I mean things like people's physical activity routines, their sleep habits, their stress management activities. These are all physiotherapy relevant examples of behaviors you may want to assess as part of care. If you must talk about weight, ask permission before doing so explicitly. And if they say no, then respect that, right? This is informed consent. They have said, no, I don't want to speak about this. If you are going to talk about weight, you can follow their language or just use the term weight. In survey studies around word preference, weight is common. So if you may be someone who is a fat activist, you may be seeing someone who's a fat activist, and they may use the word fat in a neutral way. So that's sort of a signal that you are, they're not using it in a self-deprecating way, but the signal that you're with someone who has done some work to unpack anti-fatness and pro-fitness in their own life. You're not going to comment on changing weight, and especially do not praise reduced weight. Right? Body weight reduction can be cancer, it can be an eating disorder, it can be depression, it can be, as per the gallery, that example of a pretty life-threatening, serious condition in terms of at least her baby's life. So sorry, I accidentally, what just happened? I'm not sure. I lost the slide here. Sorry. So you're not going to comment on changing weight. And if people talk about reduced weight in search of praise, you stay neutral. You can ask about what's changed in their life, what's happening, and then you can reinforce positives. This prevents you from accidentally reinforcing or praising what may be an eating disorder, for example. When you're doing goal setting, you're staying focused on behaviors only. This is consistent with the self-management, coaching, all of those kinds of models, evidence-based models around goal setting you're focused on behaviors, because behaviors, the actual actions that people take in their lives, that's something that they may have to do a lot of work to make it happen in a way that's feasible in their life, but it is within their control. Sorry, I'm very confused about what's happening with the slides. Okay, so you're going to keep focused on actions and know that a lot of people treat losing weight as a behavior. It's not, it's an outcome. The outcomes that follow behavior change are never guaranteed, right? That's not how probability works. That's why we focus on action. So success is defined by following through with actions listed in goals, problem solving when needed to help support them. In terms of rapport building, a study of Norwegian physiotherapists who worked in bariatric programs helps us think through the challenges of rapport building. The researchers found that the mainly thin-bodied physiotherapists tried to build rapport by speaking of managing their own past injuries. This implied an equivalence to that of the challenge of living in a fatter body, which experienced routine stigma. So this ignores, this attempt to build rapport this way, ignores the impact of stigma and may actually block rapport. It's better to say, I haven't had that experience myself. Would you like to tell me more to help me understand? So you're going to be thinking about how you do this and how your privilege influences how you build rapport. The other thing you want to do is offer positive support or emotional rapport statements that normalize people's experiences. So as we all know from attempts to change our behaviors, mine is to try to reduce my screen time. Those are really hard. We all find changing our everyday routines incredibly difficult. There's nothing unique to that about people who, based on their body size, right? So you can explicitly say you're not alone, like everybody finds this hard, you're making really good progress, but you are, you're doing just fine. You're doing just like all the rest of us. This stuff is hard. So you are validating and normalizing. And also we need to always be thinking about what we're communicating unintentionally through our verbal tone, our voice, and our posture. You occasionally will have people essentially communicating sort of self-stigma or stigma directed toward the self in the clinic. Things like, I know I'm a failure, I just need to try harder to lose weight. Right, some people have worked on disrupting this, but some of our clients will still be fully in this self-stigma mode. And so what you can do is bring it back to behaviors. Again, supporting sustainable changes. That's the way we all make changes, is sustainable, like feasible goals that we are quite confident we can achieve, putting the pieces in place and making the changes. And outcomes are never ours in any guaranteed sense. And then we can remind people of the many and varied influences on weight, things like the medications they're taking and the smoking cessation and their sleep. You know, if people have poor sleep and have always had poor sleep, we expect that to wreak havoc on bodies, right? Stress wreaks havoc on bodies, including driving weight gain. So you can remind people that it's, this is not how weight works. The impact of what we will do here will vary depending on where they are on that internalization, but these are things that you can try. And then a big thing that I think physiotherapy has a ton of space to really embrace and do is promoting joyful physical activity. So this starts fundamentally from understanding that long-standing repeated experiences of weight stigma may mean that physical activity has been promoted only to them as a way to quote-unquote lose weight. They may have been stared or laughed at when physically active in gyms or in the outdoors. They may not have been able to find suitable clothing. It's only recently that we're really seeing fitness clothing for a range of body sizes. And often people simply don't believe them, that they're physically active, because we have, again, these weight myths that say that physical activity is associated with thinness. So our task is to support people to find joy in moving their bodies and becoming more physically vital. And if you have assessed well earlier, you have an idea of where they are with movement. And perhaps you even have a sense of what they enjoy and what they do not. So that's a place to start from. And if not, this is a chance to talk with them, right? What are the things and types of movement that they have really enjoyed in their lives, and that they would be interested maybe in trying to do more of or get back to, depending on where they are. So this is where those evidence-based behavior change support and coaching skills come in as well. And there are a range of training courses for this available. Finally, let's talk about targeted therapeutic exercises. So from a physics kind of perspective, we need to think about how body weight and distribution influences the intensity or impact of an exercise, right? So how it can shift sort of the center of body mass and change how exercises work. And unfortunately, we have yet to see commercial exercise decks or videos or verbal instructions that really do show how this works with larger bodies. So you may need to build those. You want to help people see. Sorry, this is so strange. What an exercise may look like in a bigger body in terms of positioning and where to position body fat if they're trying to get into a particular position. So I invite Liz to wrap us up with some thoughts about physiotherapy education.
Yeah, thanks, Patty. For those of us who teach in physiotherapy and with physiotherapy students, we wanted to share what we were thinking about in our own curriculum at the University of Manitoba. For example, when and if BMI or body mass index is used in case studies, does it add value? For example, is it only used for larger body types? If case studies do include the fat bodies, are they stereotype destructing? For example, are they active, otherwise healthy in other respects? When looking at your curriculum content, how do you present exercise? Do you have or teach considerations of exercise for larger bodies, the stuff that Patty was just discussing? When you're talking about physiotherapy assessment, do you teach techniques and approaches that are appropriate for larger bodies? We also encourage those of us who are teachers and for clinical instructors as well, or reflect on the words and actions that you use for teaching, that we're not always perpetuating that thinness is always good. So now take us back to that feelings wheel that we had at the very beginning. And we talked about to consider how you're feeling and what's happening in your body. And to look at the feelings wheel to help you name some emotions. Now we're talking about what you might do, your future commitments. What are some steps or first steps that you can take to reduce the potential of stigmatizing clients with larger bodies? If you are willing, you can share some of that in the Q&A. And I'll give you a couple moments to think about that and to write that. And while you're working on that, we want to acknowledge the work that the three of us have done, of course, but we also have other people to thank. And here's a list of other people that have worked on this project. And we recognize that this research, or we want to acknowledge this research, was funded by the University of Manitoba Research Grants Program. And with that, I think we will turn it to some questions.
Thank you so much to all three of you. That was an excellent session. We do have a few questions in the question and answer pod, and I want to start out with, it's more of a comment than a question, so I'll read the comment, but then I'm wondering if you have any other sources. So one of our audience members pointed out that there are some great resources for clinical environments and non-stigmatizing images that are available on obesitycanada.ca, and I'm just wondering if you have any other sources that you know of that are readily available or provide readily available resources that clinicians might want to use. And I'm thinking especially of sources to address weight myths, and also if there's any, you mentioned health-affirming literature, and so I'm wondering if there are any other places where clinicians can go to find health-affirming literature that is not biasing or prejudicial against larger bodies.
Thanks for that question. Yeah. So the University of Connecticut has the Rudd Center for Food Policy and Health, RUDD Center, and they have a wonderful media image deck there. And then the other place that we have gone to find images is Unsplash and Creative Commons are both sort of aggregators. And if you put your keywords in, we learned quite a few like Black-focused image decks and queer inclusive image decks that are also have plenty of bodily diversity in them. So look outside of just weight-focused decks. I think you can find a lot of excellent resources there. The other thing, in terms of resources, the Health at Every Size model has really been leading the way for decades at this point in time around non-stigmatizing care for people of all body sizes. And so look for Health at Every Size. There are a range of books. There are the Association for Size, Diversity, and Health is another really key resource. So there are some. I will say that physiotherapy specific hasn't really been developed, and so that is something that we will be continuing to work to develop.
Awesome, thanks very much. I have another question from an audience member, and I think the question really highlights a tension that clinicians may be feeling. At least I can understand the challenge, because on the one hand, we know that some conditions are exacerbated when somebody is a heavier body weight. So how can we sensitively talk about that or acknowledge that while also being inclusive and again, not prejudicial in how we do that? Have you got any tips or maybe some thoughts on that subject? Because I can see individuals having that concern or that thought process in their minds.
I'm jumping in here, but Liz or Sandra, if you would like to tag on, please do. This came up in our workshops with Manitoba physiotherapists as well. That, you know, one example was cardiac care, right, where we still talk a lot about weight reduction. So Obesity Canada and the recent guideline that they have developed, a set of guidelines they've developed with the Obesity Physicians of Canada, there's consistent agreement that all we expect in terms of weight reduction from lifestyle, sort of maximization of healthy lifestyles is 3 to 5% weight reduction from maximum weight. And I'm going to use the example of my mom, because she's a big influence on why I actually did this work at all. She was a nurse. She was my height. She was about 5 feet tall. And her body weighed close to 200 pounds. And so when she got involved with these walking challenges, and we ate pretty, from the health promoting standards that we recommend, we're already there. So that really wasn't the thing. When she would change her physical activity, she would experience 7, 8, 10 pound weight reduction. And that is considered success. 3 to 5% from maximum weight, right? 5% of 200 pounds is 10 pounds. It's 190 pounds. So we need to be incredibly realistic with people about what we have to offer them. Yes, it's the recommendation, but we don't actually know how to do it. We don't have, it's one thing we've learned from decades of research of attempting to make fat bodies thin, that we don't know how in a safe, health-promoting, sustainable way. So I think there's a lot of rethinking, actually, that we need to do around these things, because this is the example of where we are potentially telling people that weight is a problem without setting them up, without being able to offer support. That's one of the examples that came up earlier in the ways that we can reproduce this. So there's definite hard rethinking of what we need to be doing in our practice. What are the things, the actions that people can take that will help, regardless of whether those actions result in a change of weight or not, right? And so this is why we know physical activity is incredibly powerful in terms of how it affects sort of cardiovascular systems, right? Regardless of the impact of weight, we know it's incredibly powerful. Is that for that particular condition, is supporting physical activity going to have a big impact? So this is where I think the hard work begins, is starting to deal with this in our world, our clinical world.
Thanks for that answer. That really did cover the ground. I'm just going to ask if either of the other speakers wanted to add anything before we go to our next question.
This is Liz. I was just going to reinforce exactly what Patty said about, yes, specifically regarding joint pain. Some of the recommendations do include weight reduction. That's only one of the recommendations. So there's so many in that focus on being physically active. And a lot more recent evidence is showing that that's actually more helpful. And again, reinforcing that, so being physically active, regardless of whether that results in weight change, is really helpful, specifically for joint pain.
I think that's a great point. Thanks for jumping in there. I'm going to move on to another question from one of our audience members who asked if a gender or an ethno-cultural or racial angle to your research findings is planned or is appropriate, because fatness may be perceived differently by different groups. And I'm just wondering, have you looked at that? Is that part of the future research, or is that something you're aware of happening by other researchers involved in this area?
It's Sandra here, and I guess I can start that answer. And yes, I think those are definitely relevant areas that deserve more consideration. It's a bit difficult to, certainly we can look at gender within the physiotherapy community. But again, our sample sizes, even if we go all the way across Canada, will be relatively small. But I think even some of those questions are interesting more at a societal level. So even in studies that are not specific to physiotherapists, they could provide important answers to some of those questions. So yes, we would like to basically collect data in larger sample sizes and include more variables than some of the ones that the listener has suggested would be appropriate.
Yeah, and I just to quickly add to that, the reason gender wasn't, or sex wasn't included here was because the sample size, we didn't have a big enough sample of men. It was predominantly women. At the public engagement level, I will say that we are being attentive to those things. Our biggest challenge is actually recruiting men who want to unpack these things. So there's for sure a lot of work to do, and I think qualitative and mixed methods has a lot to offer here.
I'm going to shift the conversation to something a bit more clinically, just the how-to. So we had another question from the audience asking, where do you recommend, or do you have anywhere that you recommend for finding things such as gait aids and other equipment that's appropriate for higher weight capacities to support early mobility? That may be very, very applied, but if you have any suggestions in terms of finding equipment either for purchase or also finding loan equipment, have you got any suggestions, any tips for that?
This is Liz. Of course, it varies, so much by your location. If I was doing this, I would, so I'm assuming when you're saying early mobility, I'm assuming you're thinking more of a hospital-based setting. And I think it's really important to just get a handle on what your distributors in your area are. So it could be worth having, an 15 minutes, 30 minutes of your day to call a few of the distributors and see what's available. And perhaps you can make yourself a list or a sort of a resource so that it's something that you can work from, because it's going to be so region specific. And if I'm going to encourage you, if you find that it's lacking, then you encourage those distributors to look into it a bit more.
The other thing I want to flag is that Dr. Mary Forehand is an occupational therapist faculty at the U of A, and she is now the BC Canada Scientific Director. And she has been doing, I think, a lot of work around these topics. So BC Canada and Mary Forehand both may be excellent resources for you on that.
Thanks for pointing that out. I would also add Allison Jones, who's at the University of Alberta. I believe Mary's now moved to the U of T, but Allison Jones is BT faculty at the University of Alberta, and this is also an area of research for her, so shout out to her. And yes, Mary's done a ton of work with BC Canada. I'm going to ask you a question about physical activity and promoting physical activity, sort of building on the answer you gave about focusing on active at any size. But how do you support physical activity for a client who might be avoiding activity because of negative past experiences? You touched on this in terms of people who go to the gym and feel that they're being watched or judged. Have you got any tips for supporting activity for individuals that might have had that experience and now are really adverse to it?
Yeah, this is where our communication skills and our training in that regard, right, past our graduation is so important. I think being able to ask questions about what made that difficult, like what their fears are, what they have done, what other ways they could do it. So you're supporting them problem solving, not giving people answers, but asking questions that help them see that there are, for example, opportunities that maybe I mean, now there's so many opportunities to do things at home, right? It's specifically, in the pandemic, we've just had this explosion. So if it's about being in public, what about doing something at home? It's about using questions to help them unsettle. And there are various health behavior change coaching strategies. I highly encourage people do those types of courses because motivational interviewing is one strategy, but there are many others. And it really is about helping people learn how to problem solve as opposed to telling them answers. So the other thing is to potentially, if you're in a setting where this is possible, helping work with a psychologist. Sometimes it can be just you asking questions that help you rethink about how to approach this with this person, or it could be the person seeing the clinician themselves.
And I'm just going to jump in and say that it's important to help the person understand that any physical activity is good and that it doesn't have to be traditional exercise. And so to try to investigate what types of movement that they do enjoy and what sort of situations will set them up for success in terms of being able to just integrate a little bit more movement into their days as a starting point anyway.
Thanks for that response. The last question that I have in the queue, and I think it's a really important point, one of our audience members asked about resources that are specific for pediatrics, and I think it raises the issue that children are not just tiny adults. So are there resources that you're aware of that really talk about the pediatric aspect of obesity and working with children with obesity that are specific to physiotherapy as well, I suppose?
Specific to physiotherapy, I don't know that you're going to find much. I just don't think we have done much about this in our profession. We're really at the early stages. I think I would invite people to get in touch with Christy Whitmire. She's on our research team, and she is a pediatrics. She works in the University of Manitoba Department of Pediatrics and Child Health, and this has been a concern and focus of hers. So she is the best person I can direct you to in terms of resources.
All right. I just am taking note of the time, and I would like to thank you all for joining us today. Thank you to our speakers, Patty, Sandra, and Liz, for an excellent presentation, and I will draw the presentation to a close. But thank you very much for being here, and we look forward to seeing you, or at least seeing you virtually in February for the next webinar presentation for our webinar series this year. And with that, I'll say thank you very much and have an excellent day. Goodbye, everyone.